Arrhythmogenic cardiomyopathy is difficult to diagnose, particularly as it can present with sudden cardiac death in the absence of overt structural abnormalities. Genetic screening may be one avenue to identify subclinical disease and thus prevent SCUD events. In this issue, Caruth et al. Report on the clinical findings and diagnostic yield of a gene-first screening program. The group leveraged 64,500 individuals in the Geisinger MyCode biobank with whole exome data in whom a clinically actionable loss of function desmosomal variant was identified. Variants were identified using ANOVA and comprised frame shift, stop gain, start loss, and canonical splice site variant. These participants were invited to undergo a confirmatory CAP-accredited CLEAR certified laboratory test, identifying 92 individuals from 85 distinct families with at least one pathogenic or likely pathogenic variant by ACMG ALP criteria. Of these, 64% underwent diagnostic testing and follow-up, and of 21 fulfilled at least one major 2010 task force criterion. Only 5 exhibited multiple criteria. 52% of these 21 had a variant in desmoplakin. Electrophysiological manifestations included arrhythmias, conduction defects, and repolarization abnormalities. And interestingly, none had a prior family history. Imaging was completed in 86% of carriers, 22 with CMR, 15 echo, 8 with both CMR and echo. 15 carriers had global RV dysfunction or dilatation without regional wall motion abnormalities. 10% of carriers exhibited left-dominant arrhythmogenic cardiomyopathy, including late gadolinium enhancement and cardiac MRI, and non-sustained ventricular tachycardia. 2 participants were given a new diagnosis of cardiomyopathy and underwent ICD implantation for the primary prevention of sudden cardiac death. The authors conclude that screening for desmosomal arrhythmogenic cardiomyopathy genes can uncover both classic right-dominant and left-dominant phenotypes. The most frequent finding of overt cardiomyopathy was with desmoplakin variant carriers and not plakophilin 2, which is the most frequently reported gene identified in programs with RVC. This study is important as a proof of concept for a genomics-first strategy in arrhythmogenic cardiomyopathy.